Simranpal, do you want to share from your end, or do you want us to share?
No, it's okay if you guys are sharing from your end. Should I just prompt you to like advance the slides or?
Yep, we can do that.
Sure. Okay, perfect. So we can go with that. Okay, so good afternoon, everyone. Thanks for having me. My name's Sim Dhanju. I'm a fourth year PEDS resident at CHIO. I apologize if I look a bit tired. I came off of a very busy NICU call last night, but I promise I'm awake now. So I'm just going to talk a bit about a research project I did as part of residency with essentially a narcolepsy population that we're following here at CHIO. And my supervisor for this project was Dr. Toro Perez, who's one of our neurologists. And if we want to just go to the next slide. Great. So I don't have any disclosures. I will say that initially this was presented as part of our annual resident research day, but I've modified the presentation a bit just to be a bit more suitable for a more focused sleep audience. And the next slide, please. So just as a brief overview, we'll talk a little bit about some of the current research outlook for pediatric narcolepsy, both on a global scale and across the country, before talking a bit about our study design and kind of some of our results and a few interesting points of discussion. And this was very much kind of a base study, the first of its kind at CHIO. So I think there's some potential here for it to inform future research projects as well. And the next slide, please. Yep. So narcolepsy, as I'm sure everyone is aware, is a relatively rare entity both in adults and in children, but is particularly understudied, like many things in pediatrics. To date, much of the novel research with large cohorts and pediatric populations has really been centered around Western European countries. In particular, there's been a lot of medium, large cohort studies within Italy as kind of the most common, at least common group in the research. And within Canada, previous studies on patients with narcolepsy, childhood narcolepsy, are comparatively fewer, and most of those have been coming out of sick kids in the past. And really, amongst Canada-wide, everything is still very much kind of regional, center focused. We don't really have any large kind of unifying cohorts yet. And then, yep. So why does it matter that we should research pediatric narcolepsy in the first place? So one, in the past 2 decades, we've seen a growing number of incidents in new cases, both globally and even within Canada as well. Part of this is probably being driven by increased awareness and expansion of pediatric sleep facilities, so we're just catching more of it in the first place. But with the kind of proposed autoimmune mechanism that drives narcolepsy in the first place, we've also seen an increase in cases that are sort of temporally associated with both the H1N1 pandemic and the COVID-19 pandemic. So there's probably some real world factors that are also driving a bit of a real increase in cases. And despite that growing recognition, there's still a pretty significant delay in diagnosis. A number often quoted in various studies is 10 to 15 years. So that also probably commits or contributes partly to the bimodal age distribution we see. So kind of those peaks in early to mid adolescence, and then again in the second to third decade of life. Um, And part of the reason why research is so important is that in the last decade or so, we've already seen a increase, or so we've already recognized unique pediatric features that can prompt more early diagnosis, one of those being cataplectic phases, which is an entirely pediatric specific finding and is thus far thought to correlate with early disease onset. So it can be a bit of a variable presentation. So it can be something as brief as just sort of facial motor tics with a bit of hypotonia in sort of episodic occurrences to more prolonged cases of facial drooping or sustained facial hypotonia. And it's likely that in the past, this has probably prompted some of the workup for narcolepsy into underlying neuromuscular disorders or epilepsy disorders as well. So might have also been contributing a bit to some of the diagnostic delay that we've been seeing. Um, Cataplectic facies itself is it kind of it evolves over the course of narcolepsy, so it tends to be an early feature seen before the sort of classical frank cataplexy that we see in type 1, especially. So moving on to our study, it was essentially a retrospective chart review, and we did an assessment of all patients that were referred to CHEO for workup of narcolepsy. We gathered charts over a roughly 10-year period from January to December of last year. Purely, this was a convenience measure just to correlate with the beginning of using Epic at our center. And we mined all our results from MSGs and PSL, or from MSLTs and PSGs. Perfect. So in terms of inclusion criteria, anyone who was diagnosed with either type 1 or type 2 narcolepsy, according to AASM criteria, was ultimately included for analysis. And we did allow the use of both internal and external MSGs and PSLTs. Anyone who had an indeterminate or negative workup was excluded. And there were a few instances where we just didn't have the actual final report and weren't able to gather the data that we needed. So despite some of those cases being positively diagnosed, they weren't included in our analysis. So in total, over that 10-year period, we had 51 charts that met the criteria of patients being referred to us for narcolepsy. 27 of those ultimately were diagnosed with narcolepsy, and then 9 of those charts were excluded just based on our criteria. So our final analysis used only 18, which was a bit smaller, but and then to just kind of briefly go over some of the descriptive results, we won't go through everything in the interest of time, but a few key things to highlight. Number one, the age at symptom onset for our population was a mean of 8.6 years. Age at diagnosis was 11.8, a mean of 11.8 years. The delay to diagnosis was only a mean of 3.39 years. We had about a near 50-50 split amongst males and females, and there was a slight preference towards type 1 versus type 2 narcolepsy. We did stratify all of our results on the basis of type 1 versus type 2, just to see if there were any significant differences amongst our population. And with respect to age at symptom onset, diagnosis, or delay in diagnosis, we didn't see anything. And then also looking at presenting features to determine was it EDS versus cataplexy, there were no significant differences. Worth noting, though, with a population size of 18 and a non-normally distributed population, statistical power was always going to be limited. So even if we did find significant results, it probably wouldn't have meant too much. So just a couple of the interesting points. So just including those 18 charts, essentially 35% of kids who were referred to us went on to have a positive diagnosis, which is particularly interesting given that our catchment area at CHEO represents about 1.5 million children. So it does beg the question, if we're catching 18 from this small of a cohort, how many more cases could potentially be out there that we aren't catching? The split between type 1 versus type 2 was roughly 60-40. And then EDS was still the number one feature that even children with type 1 narcolepsy endorsed as kind of their initial symptom at onset. And one interesting thing is that we're not routinely screening for cataplectic facies at CHEO. In fairness, this was probably only a recognized entity within the latter half of the 2010s. But even amongst charts in the last 4 or 5 years, it's not something we're routinely looking at. And the reason that's particularly interesting is that in contrasting our population with the literature presented previously, both in Canada and kind of globally, our kids are slightly younger at presentation and at diagnosis. So the fact that we're not looking for what is now kind of being seen as the early screening feature was an interesting finding to me, an unexpected finding. And our time to diagnosis is improved, but mind you, there's still a significant amount of variability within our population. We did have one child who was like their workup took 10 years for them to ultimately be diagnosed. And why, in particular, we're finding kids at a younger age in Ottawa is a bit unclear to us at this point. We're thinking that maybe it's reflective of the fact that specialty care within Ottawa and pediatrics is a bit more centralized. So we're the only hospital in the region that even admits pediatric patients. Our subspecialty presence in the community isn't as robust as a place like the GTA. And our community sleep labs don't routinely see kids under 13 years of age. So perhaps because most of these kids just end up being referred to us directly, we're able to find a diagnosis in a bit more of an expedient manner. And so some of the kind of limitations of the study, number one, it was retrospective in analysis. So obviously any conclusions we can make are always a bit limited in terms of their strength. We can't really infer anything more than correlation. This, as kind of an initial study, was really focused around just being descriptive. But one of the future areas that we've already identified and hopefully will kind of happen, at least at our center, is evaluating treatment response to different agents, particularly with some of the more novel agents that are coming onto the market. And given the fact that virtually none of them are approved under the age of 18, so perhaps that can be a bit of a jumping point for some clinical trials to help get these agents approved for children. And it does have significant benefit for the morbidity associated with narcolepsy. And then finally, pretty much any single center study of narcolepsy is always going to have a small population just because of the relative rarity of it. So I think it would be important to kind of think in the future about creating multi-center databases so that we have maybe regional, provincial, or maybe even hopefully one day national level databases with a large enough population to have more robust data to draw from. So kind of the important takeaways are narcolepsy in kids is still under-recognized, and despite a growing incidence, there are significant delays. Our study is the first of its kind in Ottawa, and really only amongst a handful of other studies in Canada. And so if we want to kind of capture the more diverse populations inherent to our country, it would be beneficial to kind of start thinking about doing more multi-center research. And we've already got some advancements in knowledge that are helping to recognize features that should prompt or raise our clinical suspicion of narcolepsy in kids. So it would be helpful to kind of continue that lens and see what else we can find that differentiates pediatric narcolepsy from the adult side. And that is it for me. I'm happy to take any questions. And I also just want to acknowledge my many co-investigators who all helped contribute to this study as well. Thank you all.
Little time, I guess, before the next talk. There was a question from the previous talk. Maybe Irina, you would like to comment. I'll read it out first. Let's get it up here. So there was a comment about, can you please comment on recommendations for clomipramine wean, as this can be long when starting WAKIX, so pitolisant, due to the cardiac rhythm risk. Do you wean it more quickly or not? So clomipramine wean in the context of starting a new medication like WAKIX.
I guess the short answer is I don't know. I used clomipramine under supervision during my fellowship. All I can say, slowly and gradually. And because WAKIX is on board, symptom control can be much better. And with regard to withdrawal, I think it's safe to do half of dose pretty quickly. And depending on the dose that patient is right now, clomipramine can be decrease by half relatively quickly, and then when dose is lower, then you go a little bit slower. I hope that helps.
Thanks. Yeah. Any other questions online or in person here? Not seeing any online. I think if we want to pull up our talk for our next speaker, we can stay on.